Hello.
Good.
Hello, Ms. Powell. How are you?
I'm good. How are you?
Doing well, thank you. I think everyone can see my slides, I hope. Perfect. And everyone can hear me. Great. Mhm. Oh, hmm. Check this again. Okay, I guess I'll give it a few more minutes and then we can get started.
Hi, everyone. For those that have joined, I see we're kind of coming up to 12:05 and we're already over 20. So I'd probably call this quorum, and I'm sure there'll be more to join us as they step away from morning activities. Thank you, Dr. Jevtic, for bringing your expertise with respect to thrombosis management. For those of you that haven't met him yet, he initially joined us actually doing some locum work with our medicine group and has now signed on with our hematology group, doing both benign as well as malignant hematology, and comes to us from McMaster and some extra training and expertise in thrombosis. So thank you for presenting for us today.
Thank you for the introduction and nice to meet everyone virtually. So the focus of the topic today will be anticoagulant selection and initial management of thrombosis. I do general hematology, including malignant, but I have a particular interest in thrombosis, especially autoimmune thrombophilia like antiphospholipid and HIT disorders. So really hoping to just look at some classic presentations, how we would approach difficult situations more on the inpatient side, and how we would tailor anticoagulant selection for those patients. Thank you to Fresenius Kabi, and I believe Michelle is on the line today for supporting this talk. The views I express are my own, but they have offered their generous support, and they are the primary company for enoxaparin that we use here. If possible, I do like to use polls, so I have created some poll EV questions for some of the cases we'll be going through. So if people can join either using the link or the QR code, it would be great to have some discussion and see how practice might vary amongst different providers. I'll just give everyone a second to grab that info. Okay. So SJ188. And really the focus of the talk today, so I'll go through 3 cases. The first one will focus on the use of heparin, so evidence supporting low molecular weight heparin over unfractionated heparin, particularly in medical patients, as well as use in renal dysfunction, and really with the hope of convincing everyone that low molecular weight heparins should be the go-to choice in most situations. Then we'll go through a case of unprovoked VTE and discuss the role of thrombophilia testing, both inherited and acquired thrombophilias, as well as the VTE risk with contraception and how we address that. And lastly, we'll go through a case about DOAC selection, particularly covering a recent trial of apixaban versus rivaroxaban called the COBRA trial, as well as use for DOACs in bariatric and obese patients, and go through a case of reversal and management. So just a table to quickly highlight the different anticoagulants we'll be discussing today. As many of you know, unfractionated heparin is one of the oldest anticoagulants we have. It's particularly useful because of the thought that it is easily reversible with protamine sulfate. However, some of the difficulties with unfractionated heparin include difficulty titrating. It's very resource intensive for the lab as well as for nursing, and it does carry a higher bleeding risk counterintuitively compared to low molecular weight heparin. The 3 LOMOs that we use here in Canada include enoxaparin, dalteparin, and tinzaparin. And generally, they're easy to use, weight-based, no monitoring required in most situations. But of course, there's no full reversal agent. We do have protamine sulfate that has about 60 to 70% reversal, but it's not the 100% we see with unfractionated heparin. And then we have our DOACs, so apixaban or rivaroxaban being the most commonly prescribed, as well as edox and dabigatran. Generally recommended to avoid in low creatinine clearance, although there is data now to support the use of apixaban even in end-stage renal disease. Always keeping in mind that we're reviewing a patient's medication list, looking for P-glycoprotein or CYP3A inducers and inhibitors, because these can either cause sub or supratherapeutic levels of DOAC. Typically, these are going to be your anti-drugs, so your anti-epileptics, your antibiotics, your antifungals. And then obviously avoiding DOACs in pregnancy because of the lack of data. And finally, we have warfarin, which really is now almost exclusively used in situations of mechanical valve, triple positive APS, and rarely some other situations. So on to our first case. This will be looking at the use of heparins in acute VTE. So we have a 45-year-old male who's admitted to the ICU with sepsis and multi-organ failure. He's diagnosed with an acute right superficial femoral DVT. The creatinine is found to be 420 with an eGFR of around 11. Platelets are 80 and a weight of 110 kilograms. He's initially started on unfractionated heparin because of the critical illness, but after several days, he still has not been in a therapeutic range for the PTT, and he's receiving about 2,000 units per hour. So the question is, what would be the next best step? And I'm just going to activate the poll here. I believe you can select more than one option. So, oh, perfect. And again, just a reminder, the poll name is here, and then the QR code is here if anyone still needs it. Just give that a few seconds. So far, everyone is convincingly for the LOMO, which is great. Okay. Okay, perfect. So it seems like everyone agrees that low molecular weight heparin is the best option. And so I'll just go through a little bit of what evidence supports that and how we can manage that. So just a quick review, as many of you know, unfractionated heparin is this large negatively charged molecule. The way it works is by binding to antithrombin and really facilitating its effect on both factor 10A as well as factor 2A or thrombin. As opposed to low molecular weight heparin, which is a smaller molecule that solely works through the action of 10A, as you can see here. As you can imagine, in cases of acquired or congenital antithrombin deficiency, you will have reduced activity of your heparins, and so that's where you can see potential breakthrough thrombosis or difficulty obtaining that therapeutic level of unfractionated heparin. So what is heparin resistance? It's really a vague term that hasn't been properly described. The initial definition comes from a 1994 paper when unfractionated heparin was first being introduced, and clinicians started to notice that at above a certain point, patients were just not achieving therapeutic levels, and they arbitrarily defined that as 35,000 units per day. But there's a lot of variability in current practice. So this was a nice survey done by the ISTH, which is the International Society for Thrombosis and Hemostasis, where they asked thrombosis experts, how do you define heparin resistance? And there was a lot of variability in how they defined it. So some used the classical total sum of units per day, and most would choose about 35,000, but some went for a weight-based dose of about 30 to 40 units per kilogram per hour. Just a reminder, our patient is receiving about 48,000 of units per day with the heparin right now. One of the other issues with heparin resistance is how we actually measure the efficacy of heparin. And so typically, most labs and hospitals use a PTT-based assay, which I'll remind everyone is a clot-based assay. What we're doing essentially, we take the patient plasma, we mix it with some calcium and phospholipid, and we see how long it takes for that clot to form. As you can imagine, when you're taking patients' whole plasma, you have a lot of other factors that could be contributing to that clot formation. In someone who's acutely ill, they have a lot of acute phase reactants, including increased factor 8, and all of that can contribute to a lower PTT, and thus making it not an accurate way to measure unfractionated heparin effect. Other assays we have are the anti-10A, which is a chromogenic assay, so that's less impacted by acute phase reactants or other molecules, as well as the activated clotting time, which we typically use in our cardiac cath labs. And so how reliable is the PTT? And the answer is not very. As I mentioned, PTT-based assays are subject to non-specific interference from other clotting and inflammatory factors. And when we compare it to the anti-10A, which we might consider to be a better standard, there's really poor concordance. So in a lot of studies, the concordance is about 50 to 60%, meaning that we're really missing a lot of sub and supratherapeutic patients. And this is just a really nice figure to highlight. So in one cohort of about 150 patient samples, when they looked at the anti-10A and PTT on the same sample, you can actually see that 2/3 of the patients were subtherapeutic. So 2/3 of the time, you're actually not even getting close to your appropriate therapeutic window, and they're not being properly anticoagulated. You can also see here that although supratherapeutic was the minority, you did have a lot of discrepancy between your anti-10A and PTT. Because of this, we've seen in a lot of studies and meta-analyses that unfractionated heparin has about a 4 times higher bleeding risk compared to low molecular weight heparin. So about 1 to 2% with your low mos and 4% with unfractionated. And so all of this ultimately led Sunnybrook to conduct a QI initiative that they called Avoid Heparin. And this was really a great project led by Rita Selby, where they said in 2006, we're going to remove all heparin products from the ward. The only locations in the hospital where you can get access include dialysis patients or in the cardiac ORs. And what they looked at, so their outcome wasn't necessarily bleeding or clinical outcomes, but really the risk of developing heparin-induced thrombocytopenia and the impact that has on patient care. And what they found was that after they removed heparin from traditional formulary, there was a significant decrease, as you can see with this dark gray bar, in the amount of cases of HIT after exposure to unfractionated heparin. And really by 2012, it was virtually non-existent. And they estimated, based on all of this, saving laboratory resources as well as consultations and unnecessary involvement, you saved the hospital about $260,000 a year. So that's fairly significant. And there was no clear signal that there was any increased patient harm in terms of bleeding outcomes or thrombosis. So really a lot of good data to support the fact that unfractionated heparin is not the ideal anticoagulant of choice in patients, even who may have slightly higher risk of bleeding. And that's really what led the CHEST guideline committee to recommend low molecular weight heparin over unfractionated heparin in almost every situation, with the exception of 2. So that was thrombolytic therapy use, because at the time we didn't have a lot of data about LOMO in this setting, as well as if you need a reversal agent. And so this is a really, I think, kind of vague clinical scenario of what needs a reversal agent. You could argue that even someone who is having an acute GI bleed, if it's settled down, you're likely safer to start them on low molecular weight heparin because of the lower risk of bleeding rather than unfractionated heparin, and then deal with the partial reversal of the low molecular weight heparin instead. So kind of a tricky statement, but I think that's why we still see a lot of unfractionated heparin use in the hospital. And so the other indication previously for using unfractionated heparin was in renal dysfunction, because initial guidelines recommended that we don't have enough data to support the use in creatinine clearance of less than 30 for LOMO, and there's a risk of potential accumulation. However, Wendy Lim and colleagues at McMaster really showed in a meta-analysis that if you dose adjust the LOMO, so for example, enoxaparin, you significantly reduce that risk. So with unadjusted dosing, you have about a 4-fold increased risk of bleeding, but when you dose adjust, that risk goes down to about 1 to 2% in keeping with standard bleeding risk. And so the question then became, well, tinzaparin is a larger low molecular weight heparin. It's likely less renally cleared. Is it safer than enoxaparin and dalteparin in end-stage renal disease? And so this was a really nice study out of France, where the hospital in Rennes decided to, again, eliminate the use of unfractionated heparin and fully transition to tinzaparin in their end-stage renal disease patients. They used both prophylactic and therapeutic doses. And then they performed a retrospective review looking at peak anti-10A levels 4 to 6 hours after administration. And what you can see here is that this is their max anti-10A level of 4 to 6 hours after, with both prophylactic and therapeutic dosing. And they compared it to a healthy cohort, and there was no difference in the mean anti-10A. So in the therapeutic level, it's about 0.79. So this is a typo, my apologies. Versus the healthy cohort had about a 0.85 anti-10A. And we're targeting really that 0.3 to 0.7 range. So not a significant difference. And then when they looked at bleeding outcomes, there was no significant increase in the overall bleeding rate, about 3.5%, which in our renal patients is really pretty standard. What you can see here from this figure is also all the blue dots are patients who did not bleed. The red ones are those who did. And you can see that with the exception of this one all the way up here, the patients who bled were really still within that therapeutic range of anti-10A. And so the bleeding is likely going to happen regardless of the level. And there's no evidence that it's because of the accumulation of the tinzaparin. So again, just more evidence to support that we can move away from unfractionated heparin in renal patients and really focus more on using low molecular weight heparins like tinzaparin that are pretty safe even at therapeutic doses. And so for this gentleman in the ICU who has a new acute DVT with the difficult to titrate unfractionated heparin, I think the next best step would be to switch to low molecular weight heparin. The other alternative, so if there was still a strong impetus to keep them on unfractionated heparin, I would recommend sending an anti-10A to get a better sense of what their true anticoagulant effect would be. I will just caveat that by saying anti-10As are sent out to St. Michael's Hospital. They're not done in-house. And so that's an extra cost and a delayed result that might be difficult to deal with because of that delay in getting it. So I think a pretty straightforward case, but hopefully convincing that really outside of the ICU, we should not be using unfractionated heparin. Any comments, questions, any discussion points anyone wanted to bring up before I move on? Perfect. Okay, so our second case, this is an unprovoked VTE. So 44-year-old female coming in with several days of chest pain and dyspnea. She has a CTPE that confirms extensive PE involving the central and segmental arteries bilaterally. She's on 1 liter nasal prongs and otherwise hemodynamically stable. She does use Depo-Provera for contraception, and there are no additional provoking factors or family history. She is up to date on regular cancer screening and is otherwise healthy. She was started on low molecular weight heparin and admitted to hospital. So what thrombophilia testing, if any, would you send at this time? Just get the poll started. And again, you can select more than one. Okay, good. So we have some inherited thrombophilia, some JAK2 testing. No one is sending APLAs or HIT testing so far. Okay. I'll give it a few more seconds. Okay, so we have a pretty even split. So the majority would send inherited thrombophilia and a lupus anticoagulant, and then minority would send a JAK2 as well as your antiphospholipid antibodies. Okay, great. So just a quick review about hormonal contraception and VTE risk. So as many of you know, estrogen-related contraception does carry the highest risk of VTE. And this is a really nice table summary by Leslie Skeeth and Shannon Bates that was published a few years ago, just comparing all of the different types of hormonal contraceptive and their relative risk of VTE. So as you can see with your estrogen or combined hormonal contraceptives, as you go down in higher generations with increasing estrogen concentration, you are seeing a higher risk of VTE, up to 6 to 7-fold relative risk increase. And the same to be said with your transdermal patch and the vaginal ring. Typically, I think the messaging has been that progestin-only contraceptives do not increase risk of VTE, but I will caveat that by saying certain formulations, so like your high dose greater than 5 milligrams per day or your injectable DMPA, do actually have an increased risk of VTE. So with the injectable, it's about 2 to 3-fold increase. So not a strong provoking factor, but certainly something that I would say is mild and should be taken into consideration when you're counseling a patient about their risk of recurrent VTE. One thing I want to highlight, so IUD is not, IUD is mentioned here in this table and really has no increased risk of VTE. So I typically recommend this as the safest option, but certainly subdermal implants for progestin only is also equally no increased risk of VTE. Just a reminder that if a patient is started on therapeutic anticoagulation, they do not need to stop their oral contraceptive. At the 6-month mark, if we're discussing discontinuation, then we have to remember to discuss the indication for the OCP. If there's a strong reason and there's no alternative they can use and that risk factor will remain, I typically recommend staying on low-dose prophylaxis to prevent a recurrent VTE. That's always a discussion with the patient and assessing their unique circumstance. So in this patient, she was on Depo-Provera, so she did have a mild provoking factor. And so our acquired and hereditary thrombophilias, starting with the hereditary. So this typically includes factor V Leiden, prothrombin gene mutation, and your protein C, S, and antithrombin deficiencies. And this is a nice summary table by Saskia Middledorf, published over 10 years ago, looking at kind of the prevalence of each of these thrombophilia in the population and their relative risk. And what I really want to highlight, as we know, so factor V Leiden is the most common, 5 to 20% based on the population you're looking at. And really, these thrombophilia predict the risk of a first occurrence of VTE. Okay, so as you can see, the relative risk in these patients, antithrombin being the most potent, is about 5 to 10-fold increased relative risk. And generally, protein C is also one of the more potent ones. But they are not very predictive of the risk of recurrent VTE. Okay, so when you look at the relative risk for recurrent, really a lot of them hover around that 1, 1.2, 1.4 range. So very mild provoking factors, if at all, with the potential exception of antithrombin deficiency again. And so really, I think this gives us a good background to say that if we tested a patient for a hereditary thrombophilia, it has no real implication for the discussion we'll have about discontinuing anticoagulation after the acute treatment phase. Because really, a 1.2 to 1.4 relative risk is the same that I would see in someone with increased BMI. And so I don't think that this really factors into any of our clinical decision making once we're looking at stopping the anticoagulant. We also know that factor V Leiden and prothrombin are genetic tests, whereas protein C, S, and antithrombin deficiency are clot-based assays. So these are functional assays that are done in the lab. And as we've already mentioned, when you're dealing with a clot-based or a functional assay, it's prone to a lot of influence by acute phase reactants. And so generally, these tests should not be sent, particularly protein C, S, and antithrombin, in acute thrombosis, if there's any inflammation or infection during pregnancy, because you will have a false positive protein S deficiency, in advanced liver disease, or if the patient is already on anticoagulation. Okay, so I would strongly recommend that if there's a question of hereditary thrombophilia, one, there's no role for testing in the acute phase because it will not change your initial management. And two, testing should really be done in conjunction with a hematologist or a thrombosis specialist input, because if there is a false positive or if there's a result that's ambiguous, it really might lead to extra stress on the patient, unnecessary additional investigations, and it may in the end not actually change how we approach the thrombosis and long-term anticoagulation. Okay. Moving on to our acquired thrombophilia. So these tests really should be considered if there's relevant clinical signs or symptoms, and I'll go through some of those, or if we think it will change management, i.e. after 3 to 6 months of treatment, or if we think there's a strong risk of triple positive APS requiring warfarin. So what are the acquired thrombophilias? Typically, we think of our JAK2 positive MPN. So in someone coming in with unprovoked intra-abdominal or splanchnic thrombosis, erythrocytosis, or thrombocytosis that's unexplained, we should consider sending a JAK2. Again, this is a genetic test, so it won't be influenced by acute phase reactants. PNH, or paroxysmal nocturnal hemoglobinuria. If you see a patient, particularly a young patient, with concurrent hemolysis that's unexplained or DAT negative, you should consider sending flow cytometry for this, or if there's an aplastic anemia or pancytopenia type picture. Antiphospholipid antibody syndrome. So in our pre-survey, a lot of practitioners said they would send a lupus anticoagulant. I'll remind everyone that lupus anticoagulant is also a clot-based assay. So that's kind of the theme of today. Clot-based assays are very likely to be falsely positive in the setting of acute thrombosis or on anticoagulation. So typically I will not send a lupus anticoagulant in the acute setting, but I'll wait until they come off anticoagulation and then consider sending it. Your beta-2 glycoprotein and cardiolipin antibodies are EIA-based tests, so they're not affected. So you can send those in the acute setting. But really, I wouldn't send them unless there's a history of recurrent miscarriage, any autoimmune or vasculitic type symptoms that would prompt me to suspect an APS picture. And finally, we have our heparin-induced thrombocytopenia or anti-PF4 syndromes, classically thought to be associated with heparin, usually post-cardiac surgery. But I just want to put this caveat, and so this could be a talk all on itself, but we've really broadened the understanding of what anti-PF4 syndromes are. And so where we previously had classic HIT or heparin-induced thrombocytopenia, we've now seen that with VIT and with vaccine-associated injury, you can have really any trigger stimulate these anti-PF4 antibodies and lead to an anti-PF4-like syndrome. And so how do you suspect this? What you should be looking for is typically someone coming in with an atypical thrombus. So like a renal vein thrombus, adrenal vein, CVST that's otherwise unprovoked, and they have concurrent thrombocytopenia that's not otherwise explained. So in those cases, you should have a little flag go up saying, could this be an anti-PF4 syndrome? And then contact hematology to discuss and consider additional testing. One acquired thrombophilia I do want to mention separately is cancer screening. So we see this quite a bit where patient comes in, generally young, unprovoked VTE, and there's no clear secondary cause. And so the next step is to send them for a CT cap to rule out malignancy. And so is there any benefit to actually detecting cancer with this strategy? And the group in Ottawa about 10 years ago now, led by Marc Carrier, did a really nice randomized study. So what they did was they took patients, about 800 of them, who had an unprovoked first VTE event, and they randomized them to their standard cancer screening strategy that we recommend for everyone, versus adding a CT abdomen pelvis. And I just want to highlight that the CT abdomen pelvis, it was a bit more intensive than just the standard. They did undergo a ballot protocol as well as a dedicated virtual colonoscopy and CT enterography, looking for any occult malignancy. And what they found with this study was that overall, the rates of occult cancer were pretty low, so about 4% in the entire cohort. And when you looked at the two arms, there was no difference in the rate of detecting that cancer. So about 0.93% in the limited strategy versus 1.18 if you added the abdomen pelvis. And so it really showed us that adding extra radiation, adding an extra scan was a low yield strategy for actually identifying a cancer. And the cancers they ended up missing that did present in the next year were 2 cases of acute leukemia, which would not have been detected by CT scan, 2 gynecological tumors, and 2 colorectal cancers. They also showed that there was no difference in the recurrent VTE or mortality in that following year. So I think it's a good kind of basis to say that in unprovoked VTE, although we may not be able to find an answer, if they're up to date on cancer screening and there's no related symptoms, there's no real indication to send for a CT abdomen pelvis. Some people might say here, oh, they didn't do a CT chest, they're missing kind of the screening, and that's a fair point. Their rationale was that a lot of the patients already received a CTPE, and so they didn't feel the need to add unnecessary radiation further for the patients. But you can consider in someone who's maybe a heavy smoker and has not had that screening already to do a CT chest. And so in our 44-year-old woman with the unprovoked or mildly provoked PE with Depo-Provera, what thrombophilia testing would you send? So I would not send any at this time, and the rationale being that none of it will change my acute management. She's up to date on cancer screening. She has a mild provoking factor, and she has no features consistent with an antiphospholipid syndrome that would make me want to send testing at this time. In terms of the initial choice of anticoagulants, so I typically start patients with submassive or larger burden PEs on low molecular weight heparin, and that's because it has some anti-inflammatory properties as well to kind of help settle down any of that acute inflammation, and then I'll transition them to a DOAC when they're ready for discharge. Any questions, comments about thrombophilia and kind of this patient scenario? Yes.
Thank you. I think some of these questions you've alluded to. I guess first off, some of our teaching around like an age cutoff for thrombophilia testing, and sometimes you hear 40. Is that still a framework that hematology uses? Is it different? Yeah. What are your thoughts on that hard cutoff?
Are you talking about inherited thrombophilia testing?
Yeah.
Yeah. So again, I have never personally sent thrombophilia testing in my practice because rarely will it ever change my practice. So I really look at the whole clinical picture. So 40 is a good thought, but I really ask for the family history because that to me is the most important. We know that patients who have a first degree relative with a history of VTE, that is a stronger risk factor for recurrent VTE than any presence of an inherited thrombophilia. So for me, if I know someone has had a mother, a father, or even a grandparent who's had VTE, that enough for me is sometimes to discuss kind of, well, you likely have an inherited component, the risk is higher, and kind of go through that with them. And then if they're really adamant about sending testing, I will consider it, but I don't typically use an age cutoff for inherited thrombophilia, no.
Thank you. And I guess further to this particular case, when we talk about provoked and unprovoked, and we have that kind of table of the different thrombophilic risk of some of these different contraceptives, would you say that some of these agents, if they have a clot, it would be provoked, and others you would still call it unprovoked, or is there just too much subtlety to it? Because for most of us, it's just, do you need this lifelong or not? And we will refer you to an expert. But curious for your thoughts.
Yeah, that's a great question. So typically anything here, like especially an estrogen containing, I will say provoked and is a strong provoking factor. Anything down here, it's more of a discussion, it's more nuanced. So I will say, because the confidence intervals are so wide, we don't really have a great estimate of how strong they are. I'll say they're a mild provoking factor, and I'll discuss with the patient, we can stop this mild provoking factor if you don't need it. You likely still have an increased risk compared to the general population, and so then it's a discussion of risk benefit, their bleeding profile, and things like that. So yeah, for anything estrogen related, I will say strong provoking. For these kind of unclear progestin related, I will have a discussion.
Thank you.
I was wondering if I could just ask a question. I'm not sure if this is off topic, but what is your long-term management of an unprovoked pulmonary embolism and the dosing of the medications that you would be using?
So again, I think it depends on the patient and kind of the discussion. Typically, unprovoked, especially for a male, I will continue indefinite. That is a recommendation. I usually use a dose-reduced DOAC after 3 to 6 months. If there's certain situations like potentially increased BMI, I might not consider reducing. So especially if they're over 120 kilograms, but that's again a bit nuanced. And then in terms of for women, again, it's a discussion. If it's a large burden PE or they had significant symptoms, I will often recommend continuing indefinite prophylaxis. If it was small, there was no DVT, they have really no clear other risk factors, I will sometimes say your risk is 25% over the next 5 years to have a recurrent VTE. If you're okay with that risk, we can stop and monitor, but it's always a discussion.
Super. Thank you very much.
I think Dr. Lee raised her hand. Oh, yeah.
Yeah, thanks so much. Just wanted to clarify because I understand from what you're saying then that the hormonal contraception you would view as technically a provoking factor. At the same time, patients could remain on OCP. I'm just wondering, from a counseling patient perspective, do you tend to suggest that they switch to something like an IUS? I'm just considering a situation where you have a very young patient, there's no other clear provoking factors, there's no family history of VTE, and they have an unprovoked VTE, and they're on the OCP. I just surmise they might be inclined to stop it, even though I'm seeing here you're saying that it's safe to stay on the OCP while on anticoagulation.
So yeah, I would say, so if they're on estrogen OCP, it's a provoked, not an unprovoked VTE, just to that little nuance. And then I would recommend switching because although it is safe to stay on, the discussion at 6 months will then be, well, what do we do? And so typically in a young patient, if they have a modifiable risk factor, it would be best to take them off anticoagulation. And so I would suggest trying to put an IUD or switch to a progestin-only contraceptive that does not have increased VTE risk, because then when it comes at 3 to 6 months, we can stop the anticoagulant safely and we don't have to worry about anything.
Perfect. Thank you so much.
Any other questions? This is a hot topic, it seems. If I could just maybe quickly here, are people convinced by the SUM study by the lack of benefit of CT scans, or are people going to continue using CT scans for unprovoked VTE screening? Just maybe if someone could say yay or nay, I'd be interested to hear.
Sorry,
yes,
me again. I always talk too much. I guess, yeah, rather than the CT screening, I guess we kind of go back to that question of colonoscopy and GI screening more so than anything. For many of our inpatients, they're often above the threshold for air quotes routine cancer screening. And so sometimes we're left kind of screening for constitutional symptoms, and it's relatively unsatisfying. But yeah, I'm curious for some of the other internist thoughts as well.
What was the age range of that studied population? Do you know?
I believe the median was around 50 to 60. I'd have to go back and check.
So a majority of them would not have had a colonoscopy, for example.
Yes, I believe the majority did not have colonoscopy.
Thank you.
All right. So on to our last case. Okay. So this is a 46-year-old woman who has actually a recent case. So she was admitted to hospital with severe abdominal pain, CBC lipase lactate normal. A CT abdomen pelvis did show an acute SMV thrombus, but there was no suspicion for ischemic bowel at the time. There were no clear provoking factors or recent surgery. She does have a history of ventral gastric banding, but no bariatric surgery otherwise. She weighs approximately 145 kilograms. She started on therapeutic inox at 120 milligrams sub-Q BID and has symptom improvement over the next few days, and she's now being planned for discharge. So what anticoagulant would people recommend or consider starting in this patient? And so continue her on the low molecular weight heparin because of her increased BMI. Consider switching to a DOAC, including a PIX, Riva, or DABI, or switch her to warfarin, again, because of the BMI, but an oral anticoagulant. Okay. Okay, so majority so far continue on the enoxaparin, but some saying we could go with a DOAC. Okay, more in favor of the enoxaparin. Okay. Good. Okay. All right. This will be a good discussion, I hope. Okay. And so just to review some of the evidence of DOACs in bariatric and obese patients, we know that in the initial DOAC trials, patients who were over 120 kilograms in particular were underrepresented. But now that we have a lot of data accumulated through various trials and using meta-analyses, we know that for 100 kilograms or BMI 35, the evidence is pretty strong that there is no worse clinical outcomes, and so we can safely prescribe DOACs in these patients. The evidence for that 120 kilograms or BMI over 40 is less, so it is a bit weaker. But ISTH and guidelines still recommend considering DOAC in these patients because we don't have a signal that they have a worsened risk of recurrent VTE or bleeding. So the guidance is still to recommend considering a DOAC. And we know that DOACs are differentially absorbed through the GI tract. So your dabigatran and rivaroxaban are most absorbed in the stomach. As you know, rivaroxaban needs to be taken with food for appropriate absorption and bioavailability. So I would generally avoid these two agents in the bariatric population, but it seems like apixaban is relatively safe. And this was a nice retrospective chart review by Barbara Gunka from McMaster and colleagues. They looked at the 4 different DOACs and they looked at different types of bariatric surgery and the peak anti-10A level post-surgery. And what they found was that in your dabigatran population, as can be expected for being absorbed in the stomach, all 4 patients who were on DABI had subtherapeutic levels. Okay, so they were not properly absorbing the DOAC and likely at increased risk for recurrent VTE. This was similarly a trend with the RIVA population, but we didn't see a strong signal. Apixaban, however, only 1 patient was subtherapeutic. So there's some evidence here that even in bariatric patients, we can consider putting them on apixaban with good therapeutic effect. We also know, so this is a new trial that was recently published in the New England Journal about a few months ago, I think, called COBRA. And so we've known for some time that apixaban seems to have a lower bleeding risk across trials, and we were never really sure why, but there was never a head-to-head to compare with rivaroxaban. And so finally, Lana Castellucci in Ottawa and the group decided to do a head-to-head trial where they took over 2,000 patients with an acute VTE and randomized them to receive either PICS or rivaroxaban. What they found was a very significant more than 50% reduction in the risk of bleeding with apixaban compared to riva in those first 3 months of use. There was also a clinically significant reduction in the risk of major bleeding. There was no difference in mortality or any other adverse event, including recurrent VTE. So we now have trial data to support that apixaban is apparently the superior bleeding profile to rivaroxaban. We're not really sure why, but we do now have a randomized trial to say that in general, I would favor apixaban for upfront start in patients. But if they are really non-compliant or it's too hard to take 2 pills a day, you can consider starting them on riva, understanding that there is a slightly higher bleeding risk profile. Okay. And so in this patient, when I actually saw her in clinic, she'd done a month of the enoxaparin and she just couldn't do it anymore. She refused. She was having a lot of bruising concerns. And so I discussed with her the evidence that it's likely safe. We don't have strong data to support it, but I switched her to apixaban and she's done very well since. So she's just on the 5 milligram PO BID dose. At this time, I would not dose reduce patients with a high BMI just because we don't know the absorption. If there's a strong inclination to dose reduce, I would recommend setting an anti-10A level after about four days of taking the DOAC to check the peak levels is appropriate. Okay. Any questions about that case? So most practitioners said to continue the inox. Has anyone been convinced to consider a DOAC in these patients? More comfortable now? The final part, I'll just cover bleeding and how we address that, especially with our DOACs. So this did not happen to this patient. I just made up the scenario, but let's say they come back 4 weeks later. She's had a fall at home with head trauma. She is shown to have a 2 centimeter subdural hematoma on CT, and the last dose of apixaban was last night. GCS15, INR, PTT, creatinine, fibrinogen are all normal. So what is the next best step? How do we approach DOAC reversal? This is our last poll. So do we give 1 unit of platelets? Do we give PCC? Do we give andexanet alpha, idarosizumab, or intensive BP control and admission to step down or ICU? I think you can choose more than one scenario. PCC, step down ICU. Okay, perfect. So no one said platelets, no one said andexanet, and no one is voting for idarucizumab. All right. Perfect. So, I think this is being recorded, but this is a great reference. These slides come from Dr. Mithawani, and he develops, along with Lana and some of the Ottawa thrombosis experts, expert guidance to manage bleeding on oral anticoagulation. So if you follow this QR code, it should take you there. But really, what we know is that with the DOACs, they generally have a favorable bleeding profile compared to warfarin. The risk of major bleeding is about 2 to 4%, maybe less with apixaban per year. And there's a significant reduction in the risk of intracranial bleeding and major bleeding compared to warfarin, but maybe a signal for higher intraluminal or GI-related bleeding. So this first step, whenever we have a patient who has bleeding on anticoagulation, is it severe? So particularly hemodynamic instability, a critical site of bleeding, so intracranial, like in this patient, or a limb-threatening bleed. And once we've identified that, we do our basic kind of supportive care measures. So we hold the anticoagulant, resuscitate, and always remember to consider adjunctive therapies like TXA or tranexamic acid, particularly in non-GI related bleeding. Okay. The next step, so I'm sure everyone knows with warfarin, what we need is a stat INR because we really want to see is there anticoagulant on board. With our DOACs, just a reminder that none of the coagulation tests have any reliability to show if there is any anticoagulant effect on board. So PT, INR, PTT, if they're normal, you could still have DOAC present in the body. Anti-10A is very useful, but unfortunately, again, it is a send out. So by the time it comes back, you've likely already missed your window to act. So the important information to get from a patient with bleeding on DOAC is when was their last dose? What dose have they been taking and how consistently? What is their renal function? And what is their weight? Okay, because all of these will impact the metabolism of the drug. If you've confirmed, yes, this is a severe bleed, yes, they do have likely anticoagulant on board, the next step is to reverse. And so with warfarin, again, we always give vitamin K because we want that delayed effect, versus PCC, we also give upfront because that's the acute treatment. And so PCC is typically dosed based on the INR with a maximum dose of about 3,000 units. And this is just a nice reference table here. If you don't know the INR and don't have a good weight, you can just give 2,000 units as a standard dose and reassess. Dabigatran is the only DOAC that has a dedicated reversal agent, and that is idarucizumab. It's given as a 5-gram dose in 2 divided doses of 2.5 grams within 15 minutes of each other. Okay. And then our other DOACs, apixaban, riba, and adox. Unfortunately, we only have PCC as a potential reversal agent. A fixed dose of 2,000 units is typically what we recommend. And I just want to highlight, so some people may have heard about andexanet alpha as a dedicated reversal agent for the DOACs. This has now been pulled from market. So the company tried to push it. It was approved by the FDA based on the Anexa trials, but there was really not enough uptake in hospitals because of the poor data supporting it. And so they have removed it from market. Okay, so remove it from your minds. We only have PCC as potential for a PIX and RIBA reversal. And where is the data kind of supporting PCC? So a lot of these are prospective cohort studies where we've looked at administering 2,000 units in a fixed dose. The hemostasis appears to be pretty good, about 70 to 80% with PCC, but not full reversal. It's always important to remember that PCC does come with thrombotic risk, so I always counsel people to consider a 4 to 5% risk of thrombosis, arterial or venous with PCC. And when we compare that to what andexanet looked like, it also had a similar 80% hemostatic efficacy, but the thrombosis rate was double. So it had a 10% risk of thrombosis, and that's really, I think, what killed it as being an effective anticoagulant reversal for the DOACs. Okay. And then the question is always, well, the bleeding stopped, we reversed them, they're stable. How and when do we restart the anticoagulant? And there's no real good evidence for this, right? So it's always a discussion with the whole team and the patient and family about the risk benefit and kind of their tolerance for that. And in general, I always like to think, so why do they need the anticoagulant? If it was for an AFib of CHAD 0 or a distant DVT that was likely provoked, we would just say to stop it and not risk the bleeding. And then always look, so was the bleeding because of a variceal bleed, or was it a clean-based lower risk ulcer? Was it traumatic or a spontaneous intracranial bleed? Those kind of factors come into play. And then there's thrombotic risk. So again, mechanical mitral valve or aortic valve, particularly in older generation, is a higher thrombotic risk, or a high CHAD score AFib like 5 or 6. Okay, and then always steps to prevent future bleeding. So safety plans, dose adjustments as needed, and reviewing medication lists for any drug-drug interactions. Okay, so yeah, I agree. Administer 2,000 units PCC. Once they've settled, because of the acuity of their recent thrombotic event, I would restart them on anticoagulant, likely LOMO to start with slow up titration, and then consider restarting DOAC on discharge after discussion. Okay. So, and just final few moments. So thank you again to our support today. So Elonox or enoxaparin is backed by CabiCare, and they have a great patient support program. So they offer really great injection tutorial videos here in 9 different languages. So you can always recommend your patients just use this at home as well if they're having difficulties with injection or understanding. And then if you need any support for enoxaparin because of coverage or financial issues, CabiCare can always help. And I think Michelle is on the line if she wants to provide her email for anyone who needs to reach out. Okay, so thank you for having me for the grand rounds today. Happy to take any more questions or let everyone get back to work in clinic.
Thanks so much for presenting today. Yeah, really interesting, I think applicable for many of us, and lots of good discussion. So great talk.
Good question. So someone's asking if someone has started on LOMO for VTE for a few days, would you reload them? Yeah. So I do just want to clarify. So the first week for apixaban and the first 3 weeks for rivaroxaban, that's not a loading dose. So we know that when you start someone on the DOAC, they're therapeutic effectively immediately. So the reason the studies were done that way is because we actually need that higher dose, so that higher anti-10A level in the acute phase. And so it's not technically a loading dose, it's more just that acute phase risk of recurrence. And so I typically say if they've been on, let's say, 3 days of low molecular weight heparin, I just do 4 more days of apixaban at the higher dose and then down to the 5 BID. So just subtract whatever you've done of the LOMO, and then that's the rest of your lead-in dose. Great question. Okay. Well, thank you, everyone. And Ian?
Oh, yes. At what weight would you not consider using a DOAC? Like above what weight?
That's a good question. I have seen some thrombosis experts have no limit, and technically the guidelines do say there's no limit. I would always offer a DOAC and just check a level personally. So if someone, because the other option, warfarin, again, can be very difficult to titrate. So depending on the acuity of the VTE, the location and severity, I will usually offer the DOAC and just check after about 4 to 6 doses at a peak level. Okay. Thank you, everyone. Have a good day.